exciting and thought-provoking webinar, CTRL-ALK-DEL, Rebooting NSCLC with Precision ALK Inhibition. The aim of today's webinar is to take control of ALK-positive NSCLC through deeper understanding and smarter strategies. ALK to focus on the ALK fusion oncogene, which is a key driver in a subset of NSCLC patients. And finally, to delete the outdated approaches and rebooting with precision therapies that truly reflect the nature of the needs of our patients. So at Takeda, we are deeply committed to redefine the outcomes for ALK-positive NSCLC patients. This means we ensure that every therapeutic decision is grounded in precision, compassion, and innovation. And today we are honored to be joined by a global leader in thoracic oncology, Professor James Yang, who's superintendent of the National Taiwan University Cancer Center. Professor Yang has been instrumental in shaping the global understanding of ALK-driven lung cancer and continues to lead the charge in precision oncology. Dr. Yang's research focuses on lung cancer treatment and the mechanisms of multi-drug resistance of chemotherapy or targeted therapy. His basic research work includes molecular mechanisms of resistance and reversal of resistance to chemotherapeutic agents and tyrosine kinase inhibitors. His insights today will help us explore how we can truly reboot the treatment landscape for ALK-positive NSCLC. Dr. Yang has published more than 400 papers in peer-reviewed journals. He's an editor in a lot of the important editorials that we read. He's currently on the editorial board of Annals of Oncology and Lung Cancer, and is the current associate editor at Journal of Thoracic Oncology and Nature Scientific Report, amongst many other hats that he already wears. So we hope this session sparks new ideas, fosters collaboration, and most importantly, brings us closer to the shared goal of a future where every ALK-positive NSCLC patient receives the most effective personalized care that is possible. So with that, I would like to hand it over to Professor Yang to take over his talk. So over to you.
Thank you, Neha, for your kind introduction. And thank the Indian colleagues to invite me to discuss this very important issue of ALK-positive non-small cell lung cancer treatment with you tonight. So the title actually is quite interesting because this is what we do when we have problems with a computer. We push CTRL-ALK deletion, now change to ALK. That means the ALK patients, when we will discuss these patients, they seem to have pretty good outcomes when we choose the right drug. But there was also very early data showing that without right target therapies, their outcome is quite dismal. So this is what we do with our computer. Sometimes we have problem with the computer, we have to reset. So it's probably time to reset our mind to treat this ALK-positive non-small cell lung cancer, because there has been great advances in the treatment for these patients. So can I have the next slide? Yeah, okay. So these are the disclaimers. So what are the epidemiology of ALK-positive non-small cell lung cancer? We know that lung cancer is the most dreadful cancer in the world. 20% of the cancer deaths was lung origin over the world, and that's probably almost the same everywhere in the world. So if you look at the this here, this can you see my cursor? Okay, the most left Yeah, this one. Okay, previous one. Small cell lung cancer account for 10 to 15%, but this is start to decline in places where smoking is not that common. And then if you go to dissect the non-small cell lung cancer, half of these non-small cell lung cancer nowadays are adenocarcinomas, and 30% were squamous, with 20% others. In places where smoking habits are lower, for example, in some part of Asia, especially in Taiwan, more patients had adeno than the others. So we probably have 60 to 70% being diagnosed as adenocarcinoma. So if you look at the most right diagram or pie chart, you can see that nowadays adenocarcinomas are divided by the genomic alterations that we can detect upfront at the time of diagnosis. And this is a state-of-art treatment that we have to do diagnosis first, because each category of adenocarcinomas need a very different treatment paradigms. So as you can see, and this is a Western population where 30% of the patients at the time of diagnosis of stage 4 disease, they had KRAS mutation, and 15% EGFR. But yet, I think everybody understand that in certain part of East Asia, EGFR mutation were diagnosed much more than KRAS. So, for example, in Taiwan or Japan, Korea, EGFR mutations are detected in about half of the patient with adenocarcinomas, where KRAS only consists of 10% or less than 10%. So these two are some differences between the West and East population. And I know that in India, there are multiple ethnicities, thus the proportions may be different in different part of India. And I'm actually eager to learn what is the difference between each different regions of India. But anyway, at the time of diagnosis, you need to do the test. But our role today is to discuss the ALK fusion, which is, as you can see here, listed 5%. Okay, and this is usually the same worldwide. So let's go to the next slide. And one interesting thing about these what we call driver mutations is that they are mutually exclusive, meaning that at the time of diagnosis, if you detect one patient with ALK fusion, most of the time, or 99% of the time, or more than 99% actually, it was less than 0.1% in the French study. Patient will not have other driver mutations. So vice versa. So if you have EGFR mutation, you don't have ALK fusions. So this is true for these. Nowadays, we have 10 driver mutations being discussed in adenocarcinoma of the lung. So it is very important to know which genomic alteration these patients have at the time of diagnosis. So if we look at the ALK fusions, so this is a fusion that was found by Dr. Mano in Tokyo University in 2007, published. But he discovered this fusion protein in lung specimens in 4% of Japanese patients. Using differential display. Dr. Mano was a hematologist, so he actually was looking for novel fusion proteins in solid tumor, at that time lung cancer, and what he has found was these recurrent fusion protein. We know that fusion proteins or proteins that are created by fusion of two different DNA and the chimeric proteins can be found incidentally in some of the solid tumors, but it is quite infrequent to find so-called recurrent or consistent similar fusion proteins. So this is probably the first example that recurrent fusion proteins were discovered in solid tumor, but fusion proteins are commonly found in hematological malignancies. And Dr. Mano being a hematologist, so he was keen to figure out whether this recurrent protein is actually oncogenic. Thus, he did an experiment to use either EML4, this is a gene that we don't know too much about its function, and the other part of the fusion protein ALK, which stands for anaplastic lymphoma kinase. It is a pathognomonic gene in anaplastic lymphoma or CD30 positive lymphoma. So when he looked at this, he think or in his gut, he thought that this is a gut feeling. This should be oncogenic. So he did a series of experimentations, and for example, to inoculate EML4 or ALK to mice, and they did not grow into tumor. But if you inoculate fusion proteins, the tumors will, xenografts will grow very fast. So he was quite so excited to find these fusion proteins, but yet the next step is to show that indeed they are oncogenic and it is important in human beings or human tumors. So the only proof is to treat these patients with ALK kinase. We know that the kinase resides in ALKs in these fusion proteins. So by inhibiting the kinase part of these fusion proteins, the oncogenic properties should be diminished. Thus, a human experimentation is important. So he looked around and found that there was no ALK specific kinase being tested in humans, but there was a drug called crizotinib, and it was being tested as a MET kinase in Korea in phase 1 study. But that crizotinib also have some ALK activity. Actually, the activity was 20 nanomolar. Thus, he think that this might be a solution to treat these patients. Thus, he sent some of these patients who were tested ALK positive to Seoul and participated in phase 1 study. And most of these patients actually responded. Thus, crizotinib was originally developed as a MET kinase inhibitor, but now switch its gears to collect patients with ALK fusions. So how do we find ALK fusion proteins? In fact, the most traditional way to find fusion protein is to use so-called reverse transcriptase polymerase chain reaction, or RT-PCR, because then you have two primers, one in ALK, the other in EML4. So if you put in these two primers, and they can come up with a segment of cDNA. That means these two are fused in the genomes. And if you cannot find anything, that means these genes are very far away, so you cannot find them. You cannot have these transcripts being formed into cDNA. So this was a very easy way to find fusion proteins by RNA testing, but yet it is not common in pathological or clinical pathology lab to harness this technology. Thus, there are other ways to detect ALK fusions. One of them being developed at that time as a standard was so-called break-apart FISH. What is break-apart FISH? We know fluorescence in situ hybridization was the test. Is a test to use luminescence to light up the genome to the gene. So if you have the probe of the ALK part and the EMF4 part, they should be very far away if these two genes are not fused. But if genomically these two genes are fused, then the two colors will fuse. So FISH has been used to detect fusion proteins quite commonly in clinical pathology laboratory right now. But still, FISH is quite cumbersome, and it will damage your vision. Thus, it is important to the next step to use ALK immunohistochemistry. Why we can use ALK immunohistochemistry to detect ALK fusions? Although in theory, ALK immunohistochemistry will detect all ALK proteins, but in fact, ALK proteins will not express in any of the cells in normal lung or most of the tissues in the body. Thus, if you can detect ALK, that means this most likely should be a ALK fusion. But even that, the ALK fusion is very, very scarce. So you need a intensified immunohistochemistry. As we can see from the previous slide, there are multiple ALK fusions. Therefore, nowadays, the diagnostics tool are mostly next generation sequencing, but the best one to use is probably RNA-based. But in majority of clinical laboratories, we use immunohistochemistry as the most simple ways to detect ALK fusion, and the specificity actually was very, very high. The most frequent fusions was variant 1 that account for 50% of the ALK fusions, and about a quarter was variant 3A/B. And these two type of fusions are quite important, that they probably do have different responses to tyrosine kinase inhibitors, as we are going to tell you later on. That variant 1 actually was much more responsive, or they are less malignant than the variant 3 and B. Okay, let's go to the next slide. So I told you about the story of the first crizotinib, and that was the first patient tested was 2007. But very quick, as you can see, it was approved in 2011 by US FDA. And also approved next year by European regulatory agency, EMA. So this was the first ALK inhibitors that was useful in the clinic. That certainly changed the fate of patients with ALK fusions. We know that these patients actually had pretty poor prognosis if ALK inhibitors was not used in these patients. The second one that was tested was Novartis compound, ceritinib. Ceritinib was developed by Novartis as a second one, but in the first place, they have underwent a very rough development process. As you can see, it was approved in 2014 in United States as the second line, and in the 2015 Europe. By that time, crizotinib is already approved in the first line in Europe. At the time when ceritinib was approved in the first line in both United States and Europe, it was already 2017, where the other ALK inhibitors such as alectinib, which was in black, was already approved as second line. So as you can see, after 2014, there are multiple ALK inhibitors being developed. Ceritinib is, although it is a quite early drug to be developed. In fact, its efficacy were not bad, but the problem was its side effects, because a majority of patients had very severe epigastralgia after taking a standard dose of ceritinib at 900 milligrams. It will take a long time for Novartis to figure out that, in fact, if you take ceritinib with food, you can reduce the dose to 750 or 600, then keep the same activity, because when you measure the blood level, it was the same 600 with meal, with 900 empty stomach, but with food, the efficacy was the same, but much less side effects. So to develop this drug, it is important to develop that in the early stage to figure out the best treatment strategies, not to allow patients to allow this drug to be forgotten, because everybody will remember this ceritinib as a very difficult drug to be used. Thus, nowadays, we can show in the later on that it was recommended, but it has no market share. And alectinib, on the other hand, was much easier drug to be used with much less side effects. As you can see, first line and second line were approved in 2018. But before that, as you can see, our brigatinib, that we are going to spend a long time discussing it, was approved in 2017 as second line, and in Europe in 2019. And first line use of brigatinib was approved in 2021. We know that is already COVID age. So brigatinib certainly is a very interesting drug because it is easy to be used. It does have its side effect. We are going to discuss that in detail, but it is with its dosage and dosing administration, it is much easier compared to all the other drug, or at least on this table. Lorlatinib is the most recent one that show great efficacy, but yet we know that it does has quite a few side effects. Also, the efficacy, it is really the champion. Okay, so let's go to the next slide. So crizotinib is a first generation, as we can see. No, there is no definition of first or second generation or third generation, but we usually call crizotinib the first generation, and lorlatinib the third generation, and all the other second generation. Brigatinib, some people will call it 2.5 generations, but these generations probably just tell us the sequence that they were developed. As I told you, quizartinib has a very fast track approvals process because this is the first ALK inhibitor that showed great efficacy in patients who fail chemotherapy. So Profile 1001 was a very large phase 1 study. In fact, the study is still open because it has multiple cohort of patients to examine different population of patients, um, including MET, ALK, MET skippings, etc. So it is a very set up a example of how much a phase 1 study can do. Profile 1005 was a phase 2 study collecting patients who had been treated with chemotherapies and enrolled in the program. And you can see the response rate here was 54%, and median PFS was 8.4 months. Quite astonishing at that time and fit into the criteria of targeted therapies because this is the same as Iressa or gefitinib in EGFR mutations, quite in the similar ballpark of response rate as well as progression-free survival. Profile 1007 is a pure study in the second line after 1 line of chemoftherapy failure. The response was very similar. Profile 1014 was a phase 3 study comparing quizartinib as a second line to standard of care chemotherapy, which was pemetrexed or docetaxel. And in the same study, it was also found a very interesting result that a patient treated with pemetrexed was much better compared to those treated with docetaxel. So we know that when patients fail TKI and you have no choices, in fact, these are, although quite a few patients receive chemotherapy, but yet you should use pemetrexed at first because in that study, patients with ALK fusions respond better to pemetrexed. So in that study, you can see the PFS has reached 10.9. This is a phase 3 study, and thus it was fully approved as second line. The third line, the first line study was 1029. We're not going to discuss it too much, but the response rate and as well as the PFS was actually quite similar to the second line, which fit into our belief that for target therapy, it might be the same if you treat that as a first line or second line. Okay, let's go to the next slide. So what happens to patient with quizartinib? Every patient will progress, not every, but almost every. And majority of patients progress in the brain. So as you can see at the time of diagnosis, 15 to 35% of ALK fusion patients had brain metastasis. But at the time of progression, using quizartinib or chemotherapy, 60% had brain metastasis. This told us that probably quizartinib has less control in the brain. And in fact, quizartinib does have very low brain penetrant. So we know that although quizartinib is a very good drug, but for the brain control, it is the worst performing among all these ALK inhibitors. Okay, so but ultimately, at the end of the day, these patients will live a long time with different ALK inhibitors, but most of them will develop brain metastasis. And the other thing that we are going to emphasize is that for target therapies, we think that they are not curative. And this was shown here by multiple resistant mechanisms that can find in ALK fusion proteins treated with ALK TKIs. And there has been extensive discussion of two types of resistance. One is ALK mutation. So as we know that in fusion proteins, ALK was wild type in sequence. But in resistant patients, sometimes you can see point mutations. For example, as you can see, L1196M. So this is the same site of T790M of EGFR. So gatekeeper mutation. And the second one, G12O2R, and this mutation, in fact, is not the same. We cannot find similar sites on EGFR. It is a so-called solvent front mutation, and some others as well. So these are mutations that will hamper quizartinib to enter the pocket and to exert its effect. And for the other mutation, for other resistant mechanisms, you can find other mutations such as EGFR, HER2, KRAS, but these are actually quite uncommon in ALK resistance. So it consists of very few population of patients. So next slide. So in fact, if patients become resistant to ALK, the second choice is still another ALK fusion, ALK inhibitors. So this is the NCCN guidelines for first-line treatment. The preferred ones are alectinib, brigatinib, or lorlatinib. Nowadays, category 1. And ceritinib, as I told you, is not really recommended at this moment. Quizartinib certainly is rarely used as a first line. And for patients who are already receiving chemotherapy, the recommendation are still the same as listed here. At the time of progression, let's go to the next slide. You can separate them into asymptomatic, where you can treat the local progressors and continue the previous treatment, or you can switch to subsequent treatment. And for symptomatic, especially brain metastasis, you should use the other generations, alectinib, brigatinib, or ceritinib, lorlatinib, or and also do local treatment at the same time. And for systemic progression, you can try to use local treatment, but at the same time, you can also, if these patients have multiple lesions, local treatment is deemed impossible. Changing to other generation is quite possible. And this is the US guideline. Let's go to see EMA guidelines or European guidelines. It does have a next slide. A very different approach in that the first line treatment is still the same, but separated into oligoprogression and the systemic progression. But look at here, for systemic progression, the European guideline are very different from US in that rebiopsy now is recommended. Why rebiopsy is recommended? Because different mutations, second mutations may be used. We can use choose one of these second generation or third generation to conquer these resistant mutations. And that was shown in multiple case reports, although no good series of report, but the European guidelines accept this idea that rebiopsy is probably useful. Okay, so why is that so? Next one. Because if you look at the different mutations listed here, this seems to be a very similar, these are IC50s, but it seems to me like a microorganism and antibiotic chart that use the cultured bacteria to match to the sensitive antibiotics. So this is the same. The red ones are insensitive ones because you see high IC50s for example, gatekeeper quizartinib was resistant, and sulfentron quizartinib and alectinib were resistant, but not quizartinib, not brigatinib or lorlatinib. And so if you can look at this chart and select the right agent, which is green, you probably can do patient a favor of giving them the right choice right away with a rebiopsy and test for the mutation site. Next slide. So if we look at the good ones, which is brigatinib, alectinib, or lorlatinib, so these are the three common ones that are used in the first line. What is the difference between these three drugs? Alectinib obviously is quite important because it's quite useful, widely used. But the biggest problem is the number of tablets that need to be taken. As you can see, you need to take 4 tablets per day. And this is troublesome to some patients because the pill is actually pretty large. And lorlatinib, as I said, its problem is hypercholesterolemia. We don't know its long-term side effects. And in addition, many patients had weight gain problems as well as mental depression problems because it's good penetration to the brain, thus leaving the brigatinib as one of the interesting choice for the first-line treatment. So let's go to the next slide. Let's see what is the data about the phase 3 study. So these are ALK-positive patients diagnosed with FDA-approved kits. And in the phase 3 study, we call it Alter-1L. Patients can receive chemotherapy, and or they can be diagnosed freshly and randomized to quizartinib, at that time the standard of care, or brigatinib. Remember that brigatinib need to use half a dose or 90 milligram for 7 days as a leading dose. This was because in the earlier studies, when we used a recommended dose 180, there will be a much higher incidence of interstitial lung disease. Therefore, it is important to start with half dose for 7 days, and the ILD will reduce a lot in using this strategy. And go to the next slide. The primary endpoint was progression-free survival. 2 arms are very, very the same, as you can see here. And majority of patients come across the world, many sites, because these are rare, not really common disease, only 5% of patients. And at the data cutoff date, 2021, the follow-up was 40 months for brigatinib, so very long follow-up, and 15.2 months for quizartinib. So let's go to the next slide. So huge difference between the progression-free survival. These are the primary endpoint was Burke or blinded independent review. Huge difference. But if you look at investigator, it was even larger. And this was common because investigators tend to keep the patient in the study. Primary endpoint was met. So let's go to the next slide. And what about patients who had a response? We know that 3/4 of the patient will respond, as you can see here, 74%. And the responders will have a even longer duration of response at 33.2 months compared to 13.8 months in the quizartinib arms. Let's go to the next slide. And across the board, in the forest plot, we cannot find a defined population that can favor quizartin, meaning that there is no predictive factors to choose quizartin over brigatinib. Actually, brigatinib was much better than quizartin in all these categories of patients. Next slide, please. And one thing that is important is that the brain control is the important thing that quizartin has missed. Thus, when we analyze patients who originally had brain metastasis, the difference was huge, 24 months versus 5.6 months. So quizartin performed very bad. But for patients who had no brain metastasis, brigatinib was actually even better at 29.3 months. But this was, predicted because this brain metastasis is a prognostic factor, a poor prognostic factor. So, but there was also difference between quizartin and brigatinib. Okay, so next slide, please. And at the final population, as you can see here, there was a huge difference between these two. Thus, patient with brain metastasis certainly should choose brigatinib over quizartinib as the frontline choice. And brigatinib certainly reduce the risk of intracranial progression. Next slide, please. What about the overall survival? We know that patients who had failed quizartinib crossover to brigatinib. Thus, at the end of the day, the overall survival was not that different. But if we look at patients who had not been crossover or they have not available drug to crossover, brigatinib was much better than quizartinib. Okay, so that was a sensitivity analysis that was done for Alter-1 study. Next slide, please. And who are the patients who will benefit more? If we look at patients who originally have brain metastasis, the overall survival was better than those who receive quizartinib. So patient with brain metastasis actually will enjoy a overall survival advantage over quizartinib if you use that in the front line. And so does that mean that patient without brain metastasis will perform worse? No, it actually was the same as you look at the right Kaplan-Meier curves. So this is again another proof that brigatinib is a much better CNS controlling drug for ALK-positive patients. Next slide, please. And the safety result, is here. It's quite easy drug to be used with only one exception of beware of the interstitial lung fibrosis. 6% shown here, 3% grade 3. The one thing that need to be attended is that they occur very, very early, usually in the first or second week. So these are the only times that need to pay attention to. What I do was to take chest X-ray or ask patients to monitor their oxygen. Nowadays are quite simple. You can get it anywhere saturation. If they have change or ask patient come back first week to take a chest X-ray, you can catch these early ILD and give them steroid. You can alleviate these ILDs very quick. But if you ignore them, allow them to stay at home, sometimes they will progress into grade 3. That is not a really good idea. And for many other side effects, most of these are just paper toxicity. In fact, majority of patients that I treat, they didn't have any side effect to my concern. Let's go to the next slide. And that has translated into good quality of life. And needless to say that patient receiving brigatinib had much better quality of life compared to quizartinib. and that was tested by ELRTC quality of C30 questionnaires as well as global health status. Okay, next slide, please. And in the exploratory analysis, brigatinib showed higher overall response rate versus crizotinib, regardless of which fusion proteins variant. As we discussed earlier, that variant 1 was a more sensitive one, but compared to crizotinib, variant 3 was as effective in brigatinib compared to crizotinib. And so are the TP53 mutation status. We know that these are poor prognostic factors. Next slide, please. And in the exploratory analysis, brigatinib actually showed longer PFS versus crizotinib, regardless of these variants. And this is just a replicate the Kaplan-Meier curve to show to you that the difference was there. And these are just prognostic factors, are not predictive factors to choose any one of these drugs. Okay, next one. And the acquired resistant patterns were a little bit different in that we know brigatinib had a better control of the different point mutations. Thus, if you look at the point mutations, it was much less compared to crizotinib, which was shown in the red numbers as in the most right column. So the resist patterns may be quite different compare these two. Next one, please. So if we summarize, these are the results. Brigatinib had much better progression-free survival, duration of response compared to crizotinib, superior intracranial efficacies, manageable safety profile. It didn't have the edema problem as crizotinib or lorlatinib had, and does have superior quality of life. Okay, next one. This is a hypothetical ways to look at the depth of response. So we think that if we can control tumor better, shrink them to smaller, the heterogeneity would be much better. So this was shown in this author 1 study that brigatinib does have a deeper response compared to crizotinib. That can be shown in the next slide. So here are the target lesion shrinkage. More patients had 75 to 100% shrinkage in brigatinib arm, 56% compared to 34% in crizotinib. So deeper response can be translated into a longer control. And this is in theory, so we call it the exploratory analysis. Next one. And it can be nicely shown in the waterfall plot as everybody just eyeball it. But this is a good way to show that as well. Okay, next one, please. I think we don't have enough time to go to the few more slides, but I think we have gone through majority of issues that we need to discuss later on. So I will just close at this moment.
Thank you so much, Professor, for the talk. As interesting as it is, I do realize that we're at time, and it is time for us to move on to the next part of the meeting, which is a panel discussion. So we have a very exciting panel with us today. And this panel discussion will be led by Dr. Ullas Batra. Sir is a very distinguished name in India and abroad for thoracic oncology. So I think this group does not need an introduction, but sir is a co-director at Rajiv Gandhi Cancer Institute for Medical Oncology as well as thoracic oncology. Sir, we welcome you to the meeting, and sir, I would hand it over to you to take it forward with the panel discussion. Thank you for joining us, sir.
Fantastic, Neha. Thank you. And in the meantime that I share my slides, can you please invite my panelists also? I seem to be having some problem with my slides. Are my slides visible? Okay. Is it visible now?
Yeah. Yes.
Okay, fantastic. Great. Thank you, Neha. So I will only invite my panelists, and my first panelist is obviously Professor James Yang. It was wonderful to hear to your lecture, and
Good to see you.
Good to see you again.
Yeah.
And I was scribbling about being late night and 8:30, 9 o'clock in India, and I just checked the time in Taiwan. I think it's 11:15 p.m.
It's 11:30. Yes.
11:30 now. So I checked it around 20 minutes back. But the zeal and zest with which you spoke about brigatinib in the era of third generation TKIs is fantastic. So that was very nice. Thank you, Professor Yang. You actually made me a believer, and I hope would make some people believer at the end of this panel discussion. The second point which came to my mind, today in ALK space, when somebody gets a PFS of around 29-30 months, we're like, okay, fine. So what's so great about it? Compare this with FLORA2 and Mariposa, where at 25-26 months PFS is fantastic. Nowhere else has, the bar been risen so high other than in the ALK space. So it's so great for the patients and all of us medical oncologists to have so many choices available with us. So fantastic for that too. Now I will call my next panelist, Dr. P.N. Mahapatra from Kolkata, Dr. Ghanshyam Beswas from Bhubaneswar, Dr. P.K. Das from Delhi, Dr. Devrat Arya from Delhi, Dr. Rajat Govindan from Delhi once again, Dr. Sachin, a good friend from Chandigarh, Dr. Somnath Roy, again from Kolkata. So we have a very heady mix of we all medical oncologists here, and we look forward to some interesting discussions. We have been bred on ALK positive non-small cell lung cancer since last 5 years. So my first question goes to Devrat. Devrat, are you here? Devrat is not here. Okay, then let me go to Rajat.
Rajat, good evening.
Hi. So Rajat, first question is, what do you make out of the control ALK and DEL? What do you think is happening with the name of this symposium? What do you think that the Takeda wants to convey with that?
I think they want to convey about the various complex kind of mutations and resistant mechanisms which brigatinib boasts to sort of overcome, and so hence probably it is the ALK deletions and the control over the
control over the ALK and maybe delete some ALK TKIs from our list. Maybe that is what they're looking at. Okay, Sachin, are you here?
I'm there.
Yes, Sachin. So what is your interpretation of the title?
So they have changed ALT to ALK.
Correct.
And Microsoft had this Bill Gates, when he was asked that what improvement you could have done, and in all this, he said that he should have had a key for this rather than using 3 keys.
3 keys for that. So maybe they want to
did one TKI for deleting all the mutations.
Wow.
And the space is crowded now with then choice between lorlatinib and brigatinib.
You're not supposed to say the L word in this symposium, Sachin. I will come to Dr. Yang. Dr. Yang, your take on this.
Very
interesting name.
Yeah, I actually explain my thought in the when I started my talk. I think this is similar to what we do with a computer that is out of order. When we are stuck in the middle, we use Control-Alt-Delete to reset the computer so that we can restart, right? Yep. So the meaning of this talk, I think, is to reset our mind, that sometimes when our mind will fill with quizartinib or lorlatinib, we didn't know that there is a alternative way to treat patients such as brigatinib. It's easy and 1 pill a day. Patients usually do not have any side effects. So this is a talk that will reset our mind with our patients.
Forget about resetting our mind, Dr. Yang. Good thing is that the Microsoft has problems even in Taiwan. I thought these
We do.
used to happen.
We do. Yes.
I thought these were third world problems, you know, they were not happening in Taiwan. Good to see you in the same boat. We are also in the same boat in many other things, which I will not comment right now. Okay. So I'll just come directly to the thing, you know, we all know lung cancer is, the incidence is high, and the worst thing is the mortality is also equally high. But all these things have been changing in the last couple of, you know, in the last decade or so. I mean, when I and Sachin probably we did our residency, we passed our residency, nobody knew of EGFR, ALK and everything. And that is just to say that because we're the younger lot. The other one are, you know, slightly more senior to us. And at that time, there was only the ECOG 1494 studies, and that is all that was. So let's go to, you know, the unmet needs. Let me go to Dr. Ghansham. So Dr. Ghansham, what do you think are the significant challenges in diagnosing ALK? I mean, do you think ALK, I mean, right now, do you think in India, tissue is still an issue? NGS is an issue, IHC is an issue? Are all things cleared off right now?
I think before going for an ALK, so many of these are young patients. So when they land up with the symptoms to a physician or a pulmonologist, so they don't expect that it will be a lung cancer.
Correct.
And that's why they get late, or they are started on anti-tubercular. So that is the first thing before coming to doing, because now most of us are doing an NGS and PDL1. So that thing is sorted out, and simply there are many patients who goes for liquid biopsy. I think that part is now sorted. So many of these are still diagnosed late because these are young population. So many doesn't think that this patient population 30s, 25, or even the early 40s will get a lung cancer.
Non-smokers, definitely. So,
Non-smokers, right.
Dr. Ghansham has hit the spot. I totally resonate with what he has said.
Absolutely right. Dr.
This
Das,
happens.
Yes,
Dr.
Dr.
Das,
Das.
do you
Yes.
think the same thing happens in Indraprastha, Apollo, the premium most institute of the NCR region? Or it's only a poor man's problem in our institute?
No. See, this is a few things are important in ALK positive lung cancer. Many of the time, the patients they in the scan see big disease. Relatively, symptoms are less. So from the gut feeling, you can make out probably these are the patient, they may get ALK positive lung cancer. So what the patient they get with this, what are the challenges, particularly immunohistochemistry or the NGS or the FIS. So what are the things we see very often? We have to be very careful about this. Suppose you use Ventana ISC. One of my patients had a rheumatoid arthritis. At that time, she came with this ALK positive report with ISC positive. That was on Ventana. But somehow she wanted an expert opinion and another review. We did a NGS as well as this FIS test. In the FIS was negative. So FIS was negative, and so this thing, false positive ISC is possible. It's rare, but it's possible. So we have to keep in this mind. And also, an ISC is very short. You can get immediately the results. But suppose you want NGS, you have to wait. If you do the FIS has also challenges. At least 50 tumor cells are needed to get an. If there is some complex fusion, sometimes FIS has a challenge also. So, but as a initial testing, ISC followed by gold standard FIS, most of the time we get the answer.
Okay. So Dr. Yang, I would like to bring it to you. You know, there are two problems that came across over here. One is in India, because the ALK patients are younger, non-smokers, florid disease and tuberculosis is very endemic over here. People don't want to believe. And you run a very successful screening program in your country. So how did you convince? So let me come to screening first. Let's go to brigatinib later. Tell me about the screening program and how do you select your patients and what happens there?
Yeah. So I was also pretty old, so we gone through that tuberculosis age. Okay, so when we were students, many patients come with chest X-ray with lung nodules. The first diagnosis actually was tuberculosis. Therefore, patient will take anti-tuberculosis for everybody actually was inoculated. So it's useless to test their tuberculin test. That's hypothetical. Even though these patients do not have acid fast day positive, being positive, whatever, they are taking anti-tuberculosis initially, and it was useless if these patients are lung cancer. So biopsy was not that common because in our age, CT scan biopsy was not that common. Okay, so when we want to do a bronchoscopic biopsy, it was not that easy for lung cancer patients. So many patients were misdiagnosed at the time. But now, 30, 40 years later, we don't have that many tuberculosis. When we see these patients, our first impression is that these are lung cancer patients. And and many other diagnoses too are very ready to be used. For example, in our center, bronchoscopic biopsy with a CAT scan, or we have a hybrid bronchoscopy drone that can biopsy any small nodule that you can find in the CT scan. And so biopsy is very important to prove that these patients have lung cancer. And with that biopsy specimen, actually, you can do the diagnosis and do genomic testing. So we don't do hypothetical, treatment nowadays.
Correct. So, I mean, I was just saying that, it is good to know that you also were in the tuberculosis era. We just analyze our data. In fact, 10 years back, if we had to analyze our data, 30% of our cancer patients would have been diagnosed or would have taken ATT for some time. We just
that's right.
analyzed our last 3 years data, and the number has now come down to only 10%. So I don't know whether it is because of better diagnosis, or maybe we are sitting in Delhi, but definitely now nobody takes empirical ATT, and the knowledge is being transmitted everywhere. So that's a fantastic thing which is there.
Yeah, that's great. That should be the case. That should be the case, right?
The second thing which I wanted to ask you, Dr. Yang, was Dr. Das said about doing IHC and then confirming it by FISH or maybe by NGS.
We actually don't do that anymore because IHC has very, very high specificity. So when this patient had IHC positive, we take them as a diagnosis for ALK and then start treatment. And what time do we do FISH? If these patients do not respond, we know majority of patients will respond, right? If these patients do not respond, then we will have some doubt and do FISH or do NGS.
Okay, fair enough. So I think that is what we're following. We do IHC positive, we treat, we don't confirm by FISH. Only if the patient does not respond, we would like to go back and then see what is happening over there.
Yeah, that's right.
Go to Dr. Somnath once. And Dr. Somnath, do you look for NGS? Do you do NGS, or do you do only IHC and don't send them for NGS?
Yes, sir. Actually, we are doing preliminary IHC for ALK, and simultaneously tissue is adequate. I am preferred to do NGS also because it has some more information regarding the variant, sometimes uncommon variant, some resistant clones. So that is help me for choosing my selection of the ALK inhibitors. So I am preferably do first ALK with IHC and start treatment, and simultaneously send for the NGS for the final report.
Okay, very troubled waters. Let me see. This is what we do for our patients also, but we do say for everyone. We do a single gene testing, EGFR, ALK by IHC, and predominantly because we have a lot of research going on, we send ALK for everyone, NGS for everyone. But whether I change my treatment decisions because of that, we don't know. We'll come to that. Rajat, what do you do? What is it? I mean, if you have an IHC positive, do you really want to send and look for the variants and co-mutations? Or you say, no, I'm happy seeing that. Let me just go and start treatment. Let's just conserve tissue and let's see what happens.
True, sir. I mean, like Professor Yang mentioned, I think IHC positive upfront is just a confirmatory test, and we go ahead with treatment. And If at all the patient does not respond, we'd like to do an NGS at this stage. But in our center, of course, now that NGS is available in-house with us, so we tend to do the NGS directly and not do ALK by any other method. That is number one. And number two, I think just to mention what previous discussion was there about ALK testing. One of the challenges is testing ALK in the recurrent setting, especially many of our patients are devoid of any testing in the first line. So we tend to start them with chemo and maintenance, and eventually when the patient progresses, then we tend to ask for a biopsy and rebiopsy, and there many a times we have picked up ALK. So I think rather than lose hope in the recurrent setting in a patient of young adult, non-smoker or light smoker, we must look for any targetable mutation on progression.
Okay, so let me summarize this about what I do, and then I'll ask Dr. Yang if he agrees with this. I am a big believer of sending ALK by IHC because A, it is easily available. Two, you get the reports very early and there's a very good concordance rate. And then I start my treatment. I don't treat them differently. If you get a separate different report or not, that's a separate question. If the patient does not respond, I would definitely like to go back and see whether you do a FISH or an NGS to find out why you are not doing it. At biopsy, at progression, if you are given lorlatinib, then you do a big panel. If you are given the other things, we do a big thing. Is that all right, Dr. Yang, or what is the thing which you follow? Because also, just one more point, because if you do only NGS, and if your tumor cellularity is low, or an RNA-based panel has not been done, then you might miss ALK.
Yeah,
That's
yes, yeah, I perfectly concur with you that for many NGS panel, you will miss a lot of fusion proteins, ALK being one of them. Although 75% had common ALK fusions, the other fusions sometimes cannot be found in the NGS panel.
Okay.
So especially DNA panel is even more difficult to find. So I guess IHC obviously is much more important from the start, and in most pathology lab can do that. The only problem is the standard IHC is a standardized procedure, and it's quite expensive.
Outsource it.
Yeah, I think it can be 1/10 of a price, but the company just sell a very big box, so that's a problem. But for NGS, in fact, it really depends on which panel you are using, because many in-house panel are not that trustworthy. Even in our institution, I don't 100% trust our results. I sometimes still send out to for example, Foundation Medicine, or we have many other vendors that if they do like 1,000 per day is much better than 10 per week, right?
Yep.
So I think especially for fusion protein, it is quite difficult for some test.
Okay, Sachin, I'll come to you. Sir, yes, Sachin. So I'll come to you, and we can put the question in the question box if somebody has, and I'll ask them, because we have just not even come to the treatment part of it. So Sachin, if you have a V1 or a V3 variant, or you have a TP53 mutation or the lack of it, will your treatment differ? Dr. Yang very classically said they are prognostic, not predictive. But what do you do in a clinical practice? Let's say you do an NGS, it comes as V1 or V3. Will your treatment decision change?
Yeah, so treatment decision is not really going to change. Look, my choice till now would be lorlatinib wherever possible. Brigatinib again is just being launched. So it's the choice between crizotinib, alectinib, and lorlatinib till now. And lorlatinib is the standard of care. It is becoming the most
de facto.
Yeah. So the response rates and the PFS, the OS, and the brain metastasis control and regression. So that is best with lorlatinib across the variants. So whether it is V1, V3, or TP53, it is going to be better than other drugs.
Okay.
So there it's not going to matter actually.
So Dr. Ghansham, if I can ask you, let's say if you have a V1 without any TP53, patient doesn't really have that much of money, are you still okay giving crizotinib? And if it's a V3 or with TP53, you don't really want to do a first generation. Is it right? Or
last government scheme patient ultimately gets crizotinib only.
Government scheme people get crizotinib only, so no chance over there.
No
Okay.
chance.
Let me go to Dr. Mahapatra. Dr. Mahapatra, sir, I saw you earlier. I think Sir, does the V1, V3 make a difference in your practice, or how does it go, sir?
If it is V3, actually, I will prefer lorlatinib. Actually, if you see the data of other ALK inhibitors, actually in V3 and P53 mutation, it is better than crizotinib, but lorlatinib is the best. Actually, I'll go for lorlatinib.
As you can see, Professor Yang, we have been fed on very heavy doses of lorlatinib in the last 2 years.
Yeah,
So,
well, in fact, because we do IHC, we don't really know whether they are variant 1 or 3. So in our experience, majority of patients still respond. That means even we tend to use alectinib or brigatinib, not lorlatinib first line, simply because lorlatinib has a lot of side effects, right?
that's nice. So let's say, Professor Yang, that you have a NGS report in front of you. Somebody from a foundation has got it done, and it shows
Yeah.
a PTP53 or a V3. Will your treatment change, or you said no? I'm good with
No.
Right.
No, I will discuss with patient about the side effects they are going to get, because we know, because for lorlatinib, we know the biggest problem is weight gain and depression, as well as paresthesia, and sometimes these patients don't. These patients will be treated a long time, right?
Yeah, I mean, the median BFS at 5 years has not even been reached. You can get it both the points, and we can see. So let me go to Dr. PK Das. Dr. Das, overall survival versus quality of life. I think that is where the debate is basically going to come to, right?
Yes.
What do your patients want? I mean, there was a very nice movie, What Women Want. What do the patients want? Do they want OS? Do they want QOL? Obviously, they want both. How do you ask them? How do you decide?
See, most of the time patients are young, either working. So in this kind of situation, quality of life definitely matters a lot. So we have to take this medicine for many years. So we have seen over the years, all these drugs we are using, except the usage of brigatinib. If you see crizotinib, ceritinib, alectinib, and this lorlatinib, everybody has their experience all these drugs. Fairly, all these drugs are doing relatively well with a mild side effect profile with all. So as per this presentation and the way it seems promising, probably in few patients, we can give first line Briga and followed by a Lorla in selected patients.
1 QOL, 1 0 QOL, OS advantage. Fantastic. Let me go to Dr. Ghansham. Dr. Ghansham, QOL, OS. You can't have both.
So I want an OS first,
You
then
want an OS first.
quality of life.
You are not getting dinner, since even if it's a virtual meeting, so it's 1-1. Fantastic. Okay. Dr. Sachin.
Yeah.
QOL, OS. Forget, nobody's listening from Takeda or Ash or somebody. No? Nobody's listening.
So look, both matter, but of course,
Sachin,
OS.
Sachin, okay. Yeah, I was about to say no politics here. We will have a newsroom to do that. Tell me one.
OS.
OS, 1:2. Okay. Rajat?
Philosophical questions, but I think
Philosophical,
OS,
no, it's an everyday question that we deal with. Rajat.
OS first to discuss, sir, then QOL.
1:3 OS. Okay. Dr. Somnath.
Yeah, I also feel OS will be the primary endpoint.
Primary endpoint is there. What do the patients want? 1:4. Okay. Quality of life. I think, Dr. Yang, how do you counsel your patients? Let's say, because I'll just come to that, because in India, as you must be aware, the cost will not be that much of an issue. And I've told in many of my meetings, nobody has much of insurance over here. So people have to pay out of their own pocket. And the cost between the two of them, let's say, by and large the same. It's a young patient. What would you choose? How do you counsel? That's what we want to know from you.
Well, in fact, from crizotinib to lorlatinib or paid for by insurance. So the biggest concern, obviously, will be which one will give you the best overall survival. And if you look go to see these previous phase 3 study, all of them compared to crizotinib. None of these second or third generation compare to each other. So you don't have the answer for overall survival. That's a problem. And I agree that majority of patients still view overall survival as their primary goal to reach. And so are we, right? Quality of life certainly is important. And but then with all these drugs, I think the suffering from quality of life is much less compared to, for example, chemotherapies or many other immunotherapies. So it's less of a concern. It's now more of a concern which one will give you a best overall survival outcome.
So how do you counsel? Let me come to this young 33-year-old female who has brain mets, non-small cell lung cancer. Very smartly, she has depression at 28 years of age. I think Takeda and Roche should, encourage psychosomatic counseling for everyone. Somebody will have depression somewhere in their point of life.
I think a very important fact is that young female, they don't like to, especially these patients 30 years old or 40 years old, or even 50, they don't, the worst thing they want is weight gain.
Weight gain.
and lorlatinib certainly gives them the most weight gain. So I have a lot of problem with these patients.
We heard that in that Taiwan conference that we had over there.
So I think for alectinib, there are still some weight gain. Brigatinib actually is the most less weight gain. So I have the less problem with brigatinib for weight gain problem.
Okay. So I think we need to talk to the patients, and we need to really talk to them about the efficacy, the QOL, and the side effect profile. The time has actually come to talk to them regarding this. One major important, let's say this patient had depression and she didn't really want lorlatinib. And if you look at these 4 trials which are being compared over here, you look at it over here, the primary endpoint with alectinib was actually investigator-assessed PFS. That's our internal examiner. And with brigatinib was a BERC, that is a blinded independent radiologist who was saying that. Again to you, Professor Yang, how did the FDA approve investigator-assessed PFS? How do they even, tell us, how do they get it approved?
Well, I don't think they have a fixed idea of which one is better.
Okay.
So we are the one who see the patients.
Yep.
So I do respect investigator assessment actually.
Yep. So if you look at the investigator assessed this thing, if you look at this in alectinib, it was 25.7 versus 10.4. And brigatinib was almost equal, 24 versus 11. That is the IRC and this thing here. So by and large, if you look at the brigatinib one, it was actually 30.8 months, which was absolutely almost similar to what the ALEX trial had shown. So while we compare and contrast the trial, we also should actually look at what is the primary endpoint which was seen. Also, if you look at it, the brain mets, brigatinib did someone more better than what alectinib did. So, Dr. Sachin, let's say somebody is not willing to take lorlatinib, and you really have to choose between alectinib and brigatinib, and the patient has CNS mets. Does the HR, which is in favor of brigatinib over here, tilt your choice towards brigatinib, or you are okay with anything?
Yeah, I think it does make sense. HR with brigatinib for if brain metastases are concerned is definitely better. Of course, we can't compare both of these. These are different trials. But if according to this data, brigatinib does score over alectinib.
Slight this thing. Dr.
Yeah.
Pikidas, any your thoughts about this?
No, I absolutely agree. Agree with you. As long as till date in this kind of patient we are using alectinib, once the brigatinib is going to available, probably in this kind of patients we'll more inclined to use because of the better penetration for the brain mets and all. And lorlatinib, we know it prevents the brain mets.
Yep.
Once there is a already existing brain mets patient presenting with, probably will more inclined to give briga than alectinib.
And if I can be politically incorrect and saying it will lead to a tariff war between brigatinib and alectinib, and maybe the cost will come down. So that is also something which is nice going to happen actually over there.
And
Yes.
one question actually. If there is
Yes.
a progression, where does this liquid biopsy stands? Any
Okay.
advantage of liquid biopsy in this kind of treatment scenario?
It is close to 11:50 p.m. in Taiwan, and I'm going to wrap it up in 3 minutes. Professor Yang, liquid biopsy, and we will quickly wrap it up in 2 minutes.
I think for liquid biopsy, you certainly have to choose a very good company because for fusion protein, it is quite difficult. So for example, I really don't want to mention the name, but some company does have very good data to show that you can detect ALK fusions and other fusions in liquid. But majority of smaller companies, they don't have that expertise.
Any role while progression? I was asking that.
On progression, what would you do?
No, I don't do liquid to follow patients. I think it's too expensive. It's just another CEA, right? So we only look at the scans and determine when is the time when we need to change our practice or change our regimen.
Also,
so we only
I think,
scans, right?
yeah. Also, I think Professor Dr. BK Das, I think if it's a progression, you can do a tissue biopsy, but lorlatinib will cover most of the resistant mutations.
Exactly.
If you have lorlatinib still over there, I would actually give lorlatinib and then maybe try to do a liquid biopsy. It's a very good company with branches everywhere. Comes into the first 8 letters in English alphabets. Okay. So how do you, let's say you have Rajat, if you have given lorlatinib to start with, how would you, I mean, let's say on progression, what would you do?
Absolutely.
First line lorlatinib?
No. On first line brigatinib, and then and then what will you do? I mean, will you want to biopsy or will you want to directly go to lorlatinib?
I feel, sir, we can go directly to lorlatinib in such case. And
absolutely right. And even if you look at the post-progression data on lorlatinib from the Crown trial, if I remember rightly, good number of 50 to 60% of people actually got second generation ALK TKIs or first generation ALK TKIs, and they had a median PFS of around 6 to 8 months. So I think an ALK followed by ALK, and especially if a second generation has been given, third generation does happen in the real world scenario. I think that is what is there. What I would like to ask from Dr. Yang is regarding the ILD, and then we can probably stop. You said it's a cute drug. Nothing, because we haven't really used it, only as a matter of compassionate. Why does it cause the pneumonitis, and what do you do to mitigate this risk factor?
Well, it was known earlier on that brigatinib is both EGFR and ALK inhibitor. So it does have some EGFR inhibition activities. Thus, this is the hypothesis that because it inhibits EGFR also, it probably has some good property of that. In fact, we know that EGFR is one of the resistant mechanism, but yet it does create ILDs. We know all EGFR TKI are prone to develop ILDs in about 3 to 5%. But ALK TKIs usually is around 1 to 2%, much less. Brigatinib is the one that stand out as the highest ILDs among all ALK inhibitors. But yet, the only thing that you need is to pay attention, because these ILDs tend to come very early in the first week, for example. So if you look at watch your patients who take brigatinib, remember, only take half dose for the first week. And they have some breathing problems, to get a chest X-ray or a CAT scan right away. And you can stop the drug, give them steroid, they can recover completely.
Okay. And how common is that, Professor Yang?
In the study, it's 6% and grade 3, 3%. So it's not that common. But if you ignore that, you will have some problem, because if you see a lot of patients, you will encounter one, right?
Obviously, yes. Okay, fantastic. So I would like to summarize this, and I would like to first of all thank all the panelists for sparing time out of their busy dinner schedule, and Dr. Yang out of the sleep schedule for coming up here. Let me just summarize the talk and the moderation here. First of all, test. Don't treat empirically. No empirical tuberculosis. ALK is important. If you have an IHC, absolutely okay. No need to really confirm by FISH. If your patient does not do well, then you can confirm by FISH. If you're looking at NGS, V3 and P53 are prognostic marker. They are not predictive markers. People will do predictably bad basically in this. Please do an MRI brain for everyone, because 30 to 40% of people will have brain mets at diagnosis. First generation, second generation, third generation, definitely potency increases, but you have to talk to the patient regarding the quality of life also. Discuss with them regarding the unique side effects of all the drugs. Then take a call onto that. If the patient is not really willing for a third generation TKI, go ahead. You have nothing really to choose much between alectinib and brigatinib. Different toxicity profile. The ease of advantage, and with alectinib you will have weight gain, you can have CPK increase, you can have LFTs which get deranged. With brigatinib you have ILDs which can come in the first 1 week, so start at a lower dose, 90 mg. Call the patient, maybe do a 6-minute walk test, ask them to do SpO2 monitoring twice a day. Following progression, the data is same for both of them. Following progression, lorlatinib can be used easily. And just last word, the more the merrier for the oncologist and for the patient. And we really hope that all the participants who have listened to this have really gained something out of this. With this, once again, I would like to thank Professor Yang for staying up so late, looking so fresh. He's
No problem.
much more fresher than most of us are. Thank you, and I hand it back to the organizers. Thank you. Dr. Neha?
Yes, sir. So thank you so much. First of all, thanks to Professor Yang, as sir said, looking so fresh at this time in the night. But thank you so much, sir, for your talk. My next big thanks goes to Dr. Ullas Batra for the very engaging conversation. It was, I think I could have gone on hearing this conversation for longer. But as I understand, we are between dinner time and sleep time for most of us. And a very, very big thanks to all our panelists, Dr. P.K. Das, Dr. Ghanshyam Biswas, Dr. Sachin, Dr. P.N. Mohammed, all, Dr. Somnath Roy, Dr. Rajat Govind, so much conversation. I wish you all a very good evening, good night. Thank you so much, everyone, for joining.
Okay. I think there's
Good night.
Thank you. Bye.
Good night. Bye-bye. Good night.
Good night.